So I'm going to need a helper. I have been tasked with spending 3 to 5 minutes to summarize the entire day from an economist viewpoint. So I'm going to need a helper. I've created some crib notes while I was sitting today. And let's see if we can do this. Okay. So, Jim, that was excellent. And as we're going to find in 3 or 4 slides, it was actually perfectly predictable. I created these slides about each session. But Jim's, of course, I had to create before his session started. So when I sat through Dana's talk, what she was mainly talking about is how can we as interventionists change the beliefs and actions of parents? There's been a thread going through the entire day, and I'm really glad Jim honed in on that, is parents, parents, parents. You might not have caught it, but Dana was talking about beliefs and how they map into actions. There's an entire literature in economics about what are the best ways to change beliefs. And when we change those, how do they map into actions and outcomes in the long run and the short run that we care about? Now, Diane, Jocelyn, and Donna then provided a great aerial view of the landscape, and they taught us about the system that we need to understand. Things like, what are the economics and unique opportunities in the healthcare system? Now, from that, what you would take from the morning is to truly make change. The key is to understand what motivates people and develop programs that tap in to those motivations. That's more or less what I left with from the morning session. So then we went to the next session, and this is Raheel and Allison, and they were basically saying, well, the morning is fine, but once we develop these programs, where do we go from there? They were essentially talking about the scale-up problem. Now, an issue which Allison mentioned in passing at the end is the big deal there is what people call the voltage effect. I do a research study, and I find a 0.25 standard deviation treatment effect, but then we take that to scale, and it ends up being 0.05. And immediately what most people go to is, it must be fidelity. When you look at the implementation science literature, that's the dominant paradigm about explaining the scale-up problem. Now, if you think about how can economics help, I think about this in 3 bins. And first of all, I should say, the voltage effect is about the benefit side. When we talk about governmental programs, we talk about benefit cost analysis. Jim mentioned that in passing. That's having an understanding of the benefit side and the cost side. So when we think about scaling, we should think about items like the benefit cost ratio. How does that change as we scale up? Now, the first question then is, well, what constitutes actionable evidence? When we think about inference from a statistical sense, when should we be convinced that we can go to the next level? When should we start to scale? That's not well understood in this literature. Then people talk about representativeness of the population. Jim talked about heterogeneity. A lot of us talked about heterogeneity. You mentioned heterogeneity at the end. We didn't talk a lot about attrition, but that's obviously important too. How does the features of the population change when we go to scale? Now, where people have largely focused is what I would call representativeness of the situation. These are features like fidelity, dosage, the environment. And the way I think about it is, as a researcher, I want to give the policymaker a set of negotiables and a set of non-negotiables. And those actually come from my experimental work. So I'm actually backward inducting from what I want to tell the policymaker back to the beginning when I'm designing my experiment. These are features that are left on the sidelines because it's mostly find a large treatment effect, get published, get more money, hopefully other people will replicate it, but I don't have time for replication. Why? Because it doesn't get published in major journals, and it doesn't get funded, and then the scientific apparatus is broken down. Okay? Now, what does this leave me with? As I left for lunch, I thought, well, we're never going to realize the full benefits of our programs until we understand the science of using science. It's an entire scientific enterprise trying to understand how to use the science that we all generate. That's ill understood. That came in the morning. Now, in the afternoon, we talked about more or less case studies about great people and great programs leveraging the healthcare system. We learned about the who's, the what's, the where's. We talked about expansion of skills that might complement later learning opportunities. That's essentially the code of what was going on. Now, what I thought was a natural issue that was arising, and it came up a little bit in Jim's talk as well, is that a lot of our data are correlational in the sense that we say, if you're at the 95th percentile versus a 5th percentile kid, the 95th percentile kid has a lot better outcomes. Now, the question that we're trying to answer, of course, is if we experimentally move them from the 5th to the 95th percentile, do those kids who you've moved through your program have the same results as a kid who was naturally in the 95th percentile? Not necessarily, of course. It might matter because we might care about long-run effects of our programs, like things like what Jim was talking about. So that remains an open question for our work, whether natural variation leads to the same long-term outcomes as experimental variation. Now, from that, what naturally falls out is the economics of our problem now demands us to leverage the healthcare system. Now, this is not only because of scaling considerations, but also because of the access, which people have mentioned, and the cost side. When we think about scaling the benefit-cost ratio. There are wonderful economies of scale in the healthcare system that are set up. So now when we're talking about scaling, it's no longer a voltage effect. It might be a better benefit-cost ratio at scale. Why? Because we're reaping cost advantages through the healthcare system as we grow larger and larger. Now from Jim, obviously the beauty behind the scientific model and method, and actually that economists do it with models. Now, advocacy is nice, science is nicer. And this is where Nostradamus would be proud. It's amazing how many slides you can get through in 45 minutes. That was predictable. But I think the key to Jim is, we're all scientists now. And a big part of that is because of Jim's contributions that he's made to not only this particular area of science, but also more broadly. So I'm going to end there by saying
John,
thank you all for coming.
Can I make a remark about the healthcare system? Did you talk about the Brazilian
I don't think the Brazilian example even came up all day.
So, there is a large-scale intervention for early childhood being conducted by this guy, Osmer Terra. I don't know if anybody's heard of him. I just saw him last week. Osmer, there's a very wide scale. It's worth study. They exactly worrying about going to scale. And they are doing large-scale interventions, but at scale.
Oh, that's good.
So
that's very good.
It's a precedent, but precisely because the healthcare system has already been established.
Absolutely.
And so they can go into these areas without developing a whole new
absolutely.
So
no, thanks for pointing that out.
Yeah,
thanks for pointing
I can
that
send
out.
people information.
Yeah, send me the link or
will,
the paper, because I'm not aware of that study.
Yeah.
So I want to thank the organizers. Katie, I know that you want to say a few things about the logistics, but organizers, thank you very much for all your work.